evening. We're going to get started. It is 7 o'clock. Well, hello. I'm Mike Powers, and Mike sends his regrets. He would especially like to be here, especially given that this particular topic was one near and dear to him. So he does send his regrets. I do want to welcome all of you who are here in person and those who are with us online, and to remind us too that we're able to see these in a couple weeks as they're being recorded and they will be on the website. So welcome to University of Alaska Fairbanks' 15th Summer Healthy Living Lecture Series. We are celebrating over 100 local experts having volunteered their perspectives on topics that are important to Alaskans. And as a reminder, these lectures are the result of the vision of Michelle Bartlett and Mike Powers' vision to community and university connectivity. With that in mind, this is the final opportunity to participate in a community health needs assessment survey. We've got Laura in the back with information and insights, and that organization is collecting the data that is available in the survey. So please take part in that survey. It's very, very brief, and it does lead us, as you'll learn, to some very important pieces of our community health puzzle. So looking ahead, there are 6 more lectures in this series coming. We have chronic pain, AI and the detection of cardiac disease, heart attacks and aging, how to starve cancer, 30-minute health transformations, and AI in healthcare in Alaska. Tomorrow night, as a reminder, we have the Discover Alaska Lecture Series. So tomorrow night's subject is Missing and Murdered Indigenous People, Self-Governance as a Protective Factor, with Michelle Demert, who is the Assistant Professor of Tribal Governance at UAF. Thursday nights, we celebrate Music in the Garden at 6 p.m. It's Cold Steel Drums, and at 7:30, Effing Toes. Tonight's speaker, they will invite questions at the end of the talk, and as a reminder, I will pass you the microphone, and please speak uncomfortably close to the microphone so that people who are listening online can hear your question. Tonight's topic is Foundation Health Partners Blueprint for Services. And this serves as a great follow-up to a question that was asked last week. So I'm excited to hear what's coming. Please welcome, if you would, Kari Burrell, who is the Chief Strategy Officer at Foundation Health Partners. And as June reminds us, she was raised in Fairbanks. She's an undergraduate, worked at University of Oregon in History and Political Science. She has a master's in Public Policy and Community Planning at Harvard University. And for 2 decades has worked in public policy and community planning, including as Executive Policy Director for the State of Washington in the Governor's Office, and then as Vice Chancellor here at Administrative Services at University of Alaska Fairbanks. We also have Dr. Stephen Huffington, who is the Chief Medical Officer at Foundation Health Partners, most recently having served as the Chief Medical Officer, and we got to steal him from Alaska Regional Hospital in Anchorage. He has a bachelor's from Lipscomb University in Nashville, Tennessee. His medical school was in the University of Tennessee, and his residency in neurological and renal transplant fellowship at University of Missouri. With that, I will pass to our great speakers. Thank you.
Okay, let's do a quick check. Absolutely. Everybody getting the sound they need? See thumbs up? Looks like we're good. All right, Clark.
All right. We do have some PowerPoints, and I tend to do way too many PowerPoints. So we're going to talk pretty quickly, but we can take questions as we go, so feel free to jump in. And I tend to be the very policy wonky one, and Dr. Heffington tends to be,
I'm the color guy, so
yeah,
to
he's
speak.
very entertaining, so it's like he'll help out with explaining some of the things that we're doing. So if you could bring up the PowerPoint, that would be great. Okay, we were going to start, because Mike had asked us to talk about our blueprint for services, and that makes it sound like we have a master plan somewhere, and some of this is a living document, but we do have some things that we talk about our process, and we do have some plans in place, and so we'll talk some more about those. But it is not spread out in a strategy room at FHP, unfortunately, because that would make life a little bit easier. Okay, next slide, and that's me. Okay, so we are going to talk tonight about what is Foundation Health Partners, what is the national healthcare context that we're working in, how does FHP conduct our strategic planning, and then what are our near-term plans. So, what is Foundation Health Partners? Foundation Health Partners is a local, not-for-profit entity. We are locally owned and locally governed. We are owned by the Greater Fairbanks Community Hospital Foundation, which was started in the late 1960s. There was a flood in the late 60s that damaged St. Joseph's Hospital at the time, and it could not really continue to operate. And so local business leaders and community leaders got together to fundraise for a new hospital. The foundation owns all of the buildings and the equipment, and for many years contracted out operations to first Lutheran Health Services and then to Banner Health. And so they were the owner, and then they had a company, a contractor come in and run the businesses for them. We ended our contract with Banner Health in 2016, right at the end of 2016, and then the board decided that it's going to run, we were going to go independent and not be part of a larger health system. And so we have been independent since 2017, and frankly, most of the people who worked for the hospital as Banner Health now work for Foundation Health Partners, so it was a change in employer, but also we got some new responsibilities when we did that. So the Greater Fairbanks Community Hospital Foundation Board, and we have two of our board members here, Margaret and Dr. Hatton, are both the directors for the foundation and then also the directors over our operating entity. Next slide, that's me.
I'll be glad to do that.
Okay. Okay, so
Let's see.
that slide. This is our board of trustees, as our voting committee, and then we have a full board with some other folks on it. Next slide. This is our leadership team. So we have 8 members of our leadership team. Shelley is our Chief Executive Officer. She grew up here in Fairbanks. She is a lawyer and started with the foundation as a bond attorney, and then has been there 15 plus years, I think closer to 20 now, and is now our Chief Executive Officer. And so we have a Chief Finance Officer, basically all the basic roles are filled. And so Dr. Heffington and I are 2 members of that team. Next slide. So we are not just a hospital. We started off as just a hospital, but we have grown over time to become a health system. We don't offer everything in town, and I'll talk about that because there are lots of other healthcare providers in town. But we do offer a range of services. So we have lots of clinics. We bought the Tanana Valley Clinic in 2008. So at this current time, we have 4 primary care clinics, 15 specialty care clinics. We have 83 providers that work in those clinics, and we are proud to say that we accept all insurance types. That's part of our mission. The hospital has grown over time also. We now have 9 care units. 3 of those units, though, we contract out. So we have, for example, the emergency department is staffed by physicians with the Golden Heart Emergency Physician, so they're our contractor. And that's true also for our radiologists and for our lab pathologists. We are licensed for 152 beds. We do not generally serve that many patients. We are staffed for about 100. We can go up and down, but if we have a lot of patients, then we are frantically looking for staff because we're not staffed for 152. We are the only civilian hospital within 300 miles. The nearest next hospital is in Mat-Su, and we are accredited by the Joint Commission. Denella Center is our skilled nursing facility. It is not assisted living, it's skilled nursing only. We have 90 beds there. We do not currently serve 90. We have many people in single rooms, and so we serve about 75 patients in Denella Center, 75 residents, and we have 3 providers there.
And later, we're going to talk about an integrated health system. We'll talk about that. This is what we're talking about with an integrated health system. How do we coordinate our clinics and our hospital and our Denali Center for the flow of information, the most efficient way to take care of patients and kind of the community as a whole, rather than just a hospital focus. So it's a broader focus than just the hospital side.
Okay, so this is the continuum of care in Fairbanks, and I won't go through all of this, but when you think about a healthcare system, you start off with primary care, you might have urgent care, which is walk-in same-day care. You have specialty care services. Acute care are the hospitals in town, and there are 2. Bassett Army Community Hospital is important for the military community, and then the long-term care system, and so there are independent providers, assisted living, and skilled nursing facilities. So that's the array of services in Fairbanks. We just marked in red where Foundation Health Partners fits in those buckets. This is our service area. So we are located in the Fairbanks Northside Borough, the blue section there, but we also serve patients from outlying regions as well. So folks may get primary care in the outlying regions. Tamna Chiefs Conference has a great health clinic system. And there are some clinics in Delta and Tok, and one in Healy as well. So folks may get primary care outside in the region, but for specialty services and acute care services, they often come into Fairbanks. And so when we think about planning, we're trying to plan for the entire interior Alaska region.
And one of the unique things this creates is for many hospitals, when they talk about accepting a patient from another facility, that's a 15-minute ambulance ride. Or when they talk about transferring a patient to a level 1 trauma center, that's a 15 or 20-minute ambulance ride. Obviously for us, we sometimes have a 3-hour plane ride coming in, and then if we transfer out, it's another 2 or 3 hour plane ride down. We don't use jets, we use propellers, so it takes a while to get from where we're going. So it creates some unique challenges, also some great opportunities for us to expand our services. But it is practicing here in Alaska. Practicing in Alaska is unique. Practicing here in Alaska is very unique.
All right. We are the largest private employer in the interior. Our budget is roughly the same size as UAF's. We have fewer employees. We have 1,800-ish employees. We were named in the Alaska Business Magazine ranks all the employers in the state about how big they are. We are 11th largest, and then the 4th of the healthcare systems listed in that. Okay, so what is the National Healthcare Context? Healthcare is changing all the time, and so we're going to talk about some of the larger trends that are going on and how are we reacting to those, or how are we adapting to them.
And one of the things you may see is we're going to have some areas where we may say things that tomorrow a decision could be made in Congress that makes what we say completely irrelevant. If you can predict what's going to happen over the next week, 6 months, and 2 years, let us know, because that's part of what we are trying to react to, is predicting the future, and it's very difficult.
All right, so demographics. Nationally, our population is aging. It's interesting, life expectancy has actually dropped in some ways. People are not as healthy. There are things like the opioid epidemic contributing to that, but there are many Americans living much longer lifespans. So kind of a duality there. Senior population is growing and the working age population is actually smaller.
So when you talk about average age, when someone passes away at 19 from an overdose, that lowers the average significantly, even though there's a lot of people reaching a greater age. So right now the statistics are, if you make it to 65, you have over a 50% chance of making it to 85. If you make it to 85, you have over a 50% chance of making it to 90. So I mean, once you get there, you've already overcome some of those things, like a opioid overdose, the car crashes, the things that occur, childhood accidents that lower that average age. So even though the overall life expectancy has dropped, there are more people that are reaching an elderly age.
Which is good. Healthcare is serving that population. So locally, we are seeing the same thing. We are seeing more folks retiring in Fairbanks, so our population is aging as well. We, because historically lots of folks used to retire somewhere else, we don't really have a full array of services in Fairbanks for an older population, and so having to build that out. And we are seeing right now, when you look at the Department of Labor Trends magazine, that younger Alaskans are more likely to move away And so we are seeing some of that shift in the working age population. Nationally, the health of our population is not faring well. So when we compare ourselves to other countries, our health indicators are on sort of the downward slide in some areas. Life expectancy has declined. This started long before the pandemic. We're seeing premature deaths, and we're seeing folks with more chronic health conditions. So they are living, but they are not as healthy as they used to be. In Fairbanks, kind of happy that we're at least the same as the rest of the nation. I sometimes think we're kind of outliers, but we're on par with the national averages, but that's not good, seeing as the national averages are starting to go down a little bit. We are in the top quartile for Alaska. We are pleased that in Fairbanks we are seeing, compared to the rest of the state and compared to previous times, that our opioid incidents are declining a little bit, and there's been a lot of work on that. Physicians in our system are definitely reporting higher acuity rates, and they are reporting that patients are seeking healthcare at a later stage of illness. I just met with our new urologist, and I asked about how things are going. She's been here a month and a half, and she said, "Man, people are coming in with really late stage cancer." I'm like, "Oh man!" So she's like, that's just something that she would have thought would be caught earlier.
If you were to predict what are the factors in our society that are making us less healthy than we were compared to other societies, what things do you think have an impact on that?
What we eat.
Yeah, so our diet, our Western diet obviously is one. What else?
Sedentary.
Right, sedentary. And part of that is jobs. So we have a huge shift from less manual labor and more labor behind a computer. All of that is great in one way, but in another way, when you sit 8 hours a day or 10 hours a day, the negative effect on your body may be bigger than anything else you eat, actually. So those types of changes are ones that, as a whole, a greater disease burden.
All right, workforce shortages. This is a huge deal in healthcare. It's true in other sectors of the economy, but really big deal for us. So we are seeing healthcare workers retiring. The field is actually less attractive to younger folks for a variety of reasons. Long hours, having to work call. Patients can be more challenging. I mean, sometimes patients are angry and combative, and that is newer. So our size of the working age population is smaller, and what we expect of our healthcare workforce, we continue to expect more training, more skills. So it takes longer to become prepared to be a healthcare worker. And we do see that in Fairbanks. We are heavily reliant, at least at the hospital, on traveler staff, meaning we don't have enough people with all the specialized skills that we need, and so we are hiring staff to come up and do short stints in Fairbanks.
And the challenge there is we're generally now paying a company to go attract that staff to get them here. So instead of paying a certain amount per hour, we may pay 50 to 100% above that, because the company now is out recruiting and taking their profit off the top. It's kind of a middleman, but we don't have the resources to get 200 extra employees here over the next 2 years. So it's a challenge when you have to use that. This is a trend that started really bad in COVID, where the prices, the hospital where I was, we were paying $196 an hour for a nurse. We were paying $600 an hour for a doctor during COVID. And so that was just unsustainable. But to a certain extent, it's still out there. We don't just do that for doctors and nurses, laboratory, radiology. There's lots of areas where we are employing travelers, and they are essential for us, but they're a very expensive way to do business.
This is not just Fairbanks, though. I'd like to say that other parts of the country are also experiencing shortages, and so what we are seeing is pay for healthcare workers has gone up quite a bit, which is why healthcare costs are also going up. So we'll go to the next slide. So provider shortages. I do want to talk about this because we hear lots of folks saying, well, why can't we get more providers in town? Well, there's actually a national shortage of physicians, and increasingly we were trying to fill the gap with advanced practice professionals, but there's not even enough of them to help fill in that gap. So we are expecting a shortfall nationally, and one of the things that I put up here is a good chunk of the working population now, physicians are able to retire in the next few years, and so this will just become more of an issue. So we are affected by that in Fairbanks. We are seeing some retirements of beloved providers. We are also seeing younger providers who are like, I don't want to work the kinds of hours that the previous generation worked. I want to spend some time with family. It's very important to them, and good for them to kind of know that work-life balance. We are also seeing fewer providers that are willing to cover hospital call because their clinics are so busy. To work call means that they are working nights as well. And we are seeing, we're just competing more with other parts of the country for physicians and for providers.
And one of the many challenges as we see a shift in the generation, and we sometimes may say, oh, the younger generation doesn't want to work, and I want to challenge us on that. Oh, I am not the younger generation by any means, but I want to challenge us on that. What they're saying is we don't necessarily want to come out and spend 30 years where we don't have a life and go through 3 marriages and or have the highest rate of suicide and the highest rate of addiction in the nation. So the providers as a whole are saying we want to have a healthier life. So right now, to replace one provider that finished in 1980, you need about 1.25 providers to get the same amount of work done. But that's not necessarily a bad thing, except that we aren't putting out any more doctors than we did in 1980. And we're putting out some more mid-level or APP providers, but they're simply not enough to cover that gap with the aging population. So that 100,000 physicians projected, it's going to be about 200,000 healthcare providers that we're going to be short of. That's the entire group, so it's not just physicians.
All right, and then nationally, we talked about costs going up, partly because of labor, but there are lots of reasons why healthcare costs are going up. We are seeing sicker patients, so people come in more frequently, and they need more. Labor costs are a big part of that, and then also from the federal levels, people are trying to understand healthcare, concerned about quality. There are more and more regulatory things that we need to comply with, a lot of IT requirements, and that's just additional costs that it has to be paid for somehow. Medicare often does not cover the cost of care, so that's an issue. So the healthcare, I guess I have up here, the payments that we're getting from insurance providers are not keeping pace with the costs. Medicare doesn't cover the costs. We're currently seeing Congress looking at ways to reduce expenditures on Medicaid. And then we're also seeing from commercial insurers like Blue Cross and Aetna and MOTA, they're like, this is unsustainable. And so they're trying different things also to try to rein in costs, like bundling payments and paying for people to go out of state for surgery and different things that they're trying.
So in 1965, for every dollar that a hospital billed, they collected on average about 97 cents. By the time 1985 rolled around, that number was down to about 75 cents or so. By the time 2005 rolled around, it was down in the 45-cent range. Today, we collect 41 cents on the dollar that we bill, but in the lower 48, that number averages 27 cents on the dollar. So even though the bills are going up, the amount collecting has not adjusted. So you see these bills sometimes and think $4,000, but that may mean literally that it's an $800 payment, and that's not very uncommon, 20% of what's there. And so it's a challenge when everything else goes up, but the reimbursement is not going up to account for that. So we are paying less for salaries than we did in 2005 or 1985, certainly, but the reimbursement's not that much higher.
All right, so what are we seeing in Fairbanks? We are seeing in Fairbanks that there are some providers who feel like they cannot afford to serve Medicare patients because the reimbursements are low. And there are some that will see Medicare patients but are going to cap the number of patients on their panel that are on Medicare.
This is sometimes frustrating because you think, wait a minute, I've been a patient of this doctor for a while, but there is an economic reality. So Medicare, when you look at that spectrum, pays about 26 to 27 cents out of every dollar that you bill. And so many people here want to see Medicare. They want to see TRICARE. They want to see Medicaid. But the challenge is there's still bills to be paid. And so if you have a 100% Medicare and TRICARE clinic, you cannot physically make a living. You can't even pay your bills, much less make a living. So it's a dilemma for the providers. I think part of we'll talk about the mission earlier. The mission of this hospital is to make sure that people have access to care. But that also means that we are doing things we know that may not be the best economic. If we were a for-profit entity, we might have a different approach, but we're not. We care about the community. We care about the patients in the community. But it does mean we sometimes have access, we allow access, we want access for something that's going to lose us money. But that's okay. But in the meantime, we have to be efficient elsewhere. We'll talk about that so that we can keep that mission going for what we do. So sometimes people with Medicare or TRICARE get offended when we talk about them as a payer. It's nothing about the patients. The patients are wonderful. We love the patients. But if it costs you 30 cents on the dollar to see a patient, you're getting 27 cents. You can't make that up in volume, right? You're losing 3 cents on every patient. So it's a challenge.
I have on here that increased travel for out-of-town care reduces volumes in Fairbanks, which is obvious, but what that does mean is for those services, so for example, for orthopedic surgery, if insurers are saying, I can get that cheaper in Anchorage or I can get that cheaper in Seattle and I'm going to send the patient down, what that means is when we have an emergency and we need someone to serve at the hospital and provide that on-call care, there are fewer providers in town because they don't have enough business to have a practice in town. So this is a little bit of a concern in some of the areas where we are at a tipping point where we don't have enough volume in town to sustain certain service lines. We are not big enough to do what a lot of the country is experimenting with, which is value-based care, which are trying to give health providers a population to manage, and then they kind of manage the risk in that population, and trying to incent people to do more preventive, early primary care to reduce downstream costs. But we're just not big enough to spread that risk in our even in Fairbanks, but in Alaska, we just don't have that kind of volumes of patients. We are trying to do care models, so we'll talk more about team-based care. And we are seeing a lot of costs associated with IT, which is both a blessing and a curse. IT is kind of both of those things for us right now. Oh, technology,
There you go.
okay. So nationally, there's more requirements for IT interoperability. There are lots of cyber attacks. Healthcare is a great place to go get personal information. You have the name, you have their social security number, you have lots of private data about that person that they would like to keep that private. And so we get tons of attacks on healthcare systems. So we're spending more on preventing that. Telemedicine and remote patient monitoring. This is an opportunity. I think people used to think telemedicine is a bad thing. You should have face-to-face time with your doctors. What we are seeing is that many patients really appreciate not having to drive up from Delta to see their doctor. They would like to do it over the phone if they can, so that's good. Also, there's some opportunities for us to not staff everything one-to-one, that we could have some remote patient monitoring, and they're trying that nationally. We haven't tried that here yet locally, but we're looking at it. And then AI brings potential. So we are using it a little bit, and maybe some examples if you want to.
But I will caution you, you'll see lots of stories on AI, you'll see little videos and news stories about how great it is. Well, why don't we do that? We do that with it. AI also has a lot of downside. It is not 100% accurate. We did an audit the other day. For every 5 notes that it writes, one of them is incredibly inaccurate. Where part of the note is accurate, part of it. So it has potential, but it's still in its early stage, and we have to make sure we use it wisely and cautiously. Because every time you employ AI and it has access to your record, it is now using that record to learn. And who else does it get that record access to, right? So we have to be very careful about that. So it isn't quite the panacea that everybody thinks it is yet. We are still, I think everybody's actively exploring it, but if you just base it off of what you see on the news or what you see in little videos, you'll think AI is the next greatest thing and it's going to replace everybody in healthcare. It simply isn't going to do that, and it's not even close to where it needs to be yet. So there's still lots of steps on the journey. Because we get a lot of criticism for why don't we have AI for this, that, and the other. Lots of steps on the journey.
We are testing some AI applications. So for our primary care physicians, we are using AI scribes. So there's, someone in with their physician, and there's a scribe in the background taking notes. I will write up a note for the physician, and the physician then would have to read through to make sure it's actually accurate. We have had some providers say it's just life-changing, right? They don't have to spend the same amount of what they call pajama time. I leave the office at the end of the day and I go home and spend hours doing all of my patient notes.
And it's not even that it's just what I say that it dictates. I can say heart exam normal, lung exam normal. It doesn't say heart exam normal, it says heart regulating rhythm without rhythm. It puts those key phrases in. So, oh, you're here for an upper respiratory infection. It already knows what I'm looking for. So it has the ability. It's not just straight dictating. It is also adding in based on catchphrases. And then hopefully at the end, we'll talk about it, but hopefully at the end then it says, oh, did you know they said they were having chest pain? Did you want to, I don't see anything reacting to that. So it prompts the clinician to make sure they hit everything. Or did you know that 55, they need a colonoscopy? That sort of prompt to help the decision making.
All right. Okay, consolidation of the industry. So nationally, we are seeing fewer independent hospitals and practices and more big chains. This allows some centralization of some very specialized services. It is, however, the cause of some of the rural hospitals closing in other parts of the country. And we are seeing in some parts of the country that it's just not a hospital, they might just have an emergency room there. So an emergency room only facility was approved by Congress as an option, and so that's popping up. Fairbanks is not yet on trend for that. As we talked about earlier, we went independent. We broke away from a national system because we felt like it wasn't working for us. Chief Andrew Isaac, which is part of Town on Chiefs Conference, is expanding their services and in fact sending fewer things down to Anchorage and doing more locally. And then we are seeing some local private equity investments. The surgery center was purchased by a private equity firm for the building, not for the operation. So we're seeing a little bit of that, but it really hasn't hit Fairbanks yet. Okay, so how do we do our strategic plan? With all that going on, how do we go about figuring out what are we going to do, where are we going in the next 5 years, 10 years? So I started thinking about this, and I thought, well, we always think about what can we do to be better quality, and then we'll think about patient access. Oh, hello, Kari, this is what we call a triple aim, where we're trying to balance all three of these things. We're thinking about quality, we're thinking about access to care, and we're thinking about how do we keep the costs down. So these are the three things that we're balancing all the time. And so when we think about our projects, they're usually related to one of these things.
And sometimes these are in direct opposition, right? So I'll give you an extreme example. I could have one nurse in the hospital for every one patient. That would be great quality, right? Good patient care, but it's not sustainable financially. So I could cut us down to one nurse every 10 patients. That'd be great financially, but our quality would suffer. So it's the balance to make sure that we maintain the highest quality while also making it financially viable, because it doesn't matter how good we are if we're not here in 5 years. So how do we balance that?
All right, I am going to give this slide to Dr. Heffington. So this is about the quality pieces and
so there are a lot of competing priorities sometimes when we think about what are we trying to do within the hospital. And I tell people when we look at quality, there are certain things we do because the government tells us, but most of what we do is because it affects the patient. So the big areas that we focus on to drive our decision making and what we do, the Joint Commission, so they're a national accrediting body. They are independent from the government but work very closely with it. If you lose Joint Commission accreditation, the government will not pay you any money from Medicare, Medicaid, or TRICARE. So it is an absolute necessity. Joint Commission sets what's called a minimum standard. We want to make sure there are certain safety things in place in your hospital. Safety policies, safety processes, and safety systems. And it may be everything from the way the medical staff is organized, to the way HR works, to do you have a sprinkler system, to how your physical plant is laid out. The reason is every patient that goes into a hospital should know there's a basic level of safety that exists, right? So you should know that when a nurse takes care of you, someone has verified that that nurse has the right accreditation and education and credentials. That when a doctor does surgery, someone has verified that that doctor is qualified to do what they're doing. That the building is safe, that the pharmacy is safe, all those sorts of things. That's what the Joint Commission does as a basic level. CMS is the Centers for Medicare Services, okay, so this is who pays Medicare and Medicaid, the federal dollars that come out. But they also then, since they pay the federal dollars, use a lot of data to do quality outcomes. So they look at data, they do something called the Hospital Compare, so you can go to cms.org and you can look up any hospital and there's going to be a star rating and there's going to be a patient satisfaction rating, and then you can break down 5 different domains, and with each domain there might be up to 20 different ways that they're measuring quality, and that quality then is used for you to say, okay, I have this hospital or this hospital I can go to. Okay, now here in Fairbanks there may not be a choice, but we still want to be the highest quality we can be, and as mentioned, people do have choices now, because I can hop on a plane and be in Anchorage, I can hop on a plane and be in Seattle, right? So CMS does Hospital Compare, they do the same thing with nursing homes right now. Neither one of those have much in the way of outpatient clinics. We have voluntarily put the Joint Commission in our outpatient clinics by moving them over hospital-based so that we can assure that our clinics maintain a much higher level than what is required kind of at the basic level. So our clinics maintain a much higher level of safety. And then health equity is something that we're looking at. We're kind of being forced to look at it, but we were looking at it anyway. When you hear that, sometimes people think things like DEI and whether you agree or disagree. What health equity is about is not everybody has access to the same level of health care for many reasons. It may not just be based on where they live, but geography can affect that. If you live 150 miles outside of Fairbanks, you don't have the same access as somebody who's right next to the hospital. But other things can affect it, literacy and language. What about education? And when somebody says, hey, you need a colonoscopy for cancer screening, you don't even know what a colonoscopy is or what it means, right? Then there's also things we look at where we're seeing based on age. We need to treat people differently based on age, and those outcomes are different. And so health equity is, how are we ensuring that when patients over the age of 65 get those extra needs met when they come in so that their outcomes are what they should be? How are we ensuring that when a baby's in the hospital that they're getting the needs they need so that their outcomes? Same thing with race. You may think, well, race shouldn't have an effect other than the environment around that race, and that's not true. There are genetic factors and hereditary factors. There's a debate right now, which one affects your health more, your genetic code or your zip code? And there's a discussion back and forth because both have such a significant impact. So trying to balance all of that so that we meet the standards or exceed the standards, want to be the best quality we can be, and then we have the outside coming in to verify that. Because I can sit up and say, we're the best hospital, and confidently tell you we're the best hospital in Fairbanks. Well, how are we though, right? How does that compare? And that's not a knock on Bassett. I used to oversee them as well, but we are the best hospital in Fairbanks. But now we have outsiders coming in verifying that we're doing what we need to do.
So a lot of that is they're setting standards, but we have to figure out how we're going to get there. How do we make that work in Fairbanks? And so we have a lot of projects underway where we're testing different things.
And there is a significant expense that goes with this. This is not insignificant, but I also don't want to say it's useless. That's not the case. When we have a safety policy for suicide screening, why do we need to do that? Well, because we do have patients that are suicidal. We need to be able to screen appropriately and pick up on that. So it may seem like sometimes we're jumping through hoops or checking boxes, but that's not the case. There's patients attached to those reasons that are there.
All right, another way that we kind of scan the horizon for things that we want to address or at least be aware of is the community health needs assessment that Carol talked about, and we have opportunities for you to participate in. So we do that every 3 years. We do a new assessment of where is Fairbanks and where's our community in terms of healthiness, where are the gaps in our system, what are people experiencing that they are concerned about. We partner with lots of folks in town to do that. This is not the hospital doing this on our own. We're part of an ecosystem and we're working with our partners. And honestly, we're trying to improve health.
I love that line right there. We're trying to improve health, not just healthcare, right? Because if we improve the community health, everything's better. We use less resources, we have more available for the needs.
All right, so we talk quite a bit internally about the social drivers of health. And so when you think about a person, and Dr. Huffington just talked about this, genetics isn't on here, but it should be. That's one of the factors that would drive your health. But your individual choices, kind of your health decisions, where you live, and so that other social economic things that are surrounding that person are factors. And so when we think about healthcare, it's just, people are estimating 20% of your health outcomes are driven by the healthcare system, and the other 80% are from other things. And so when we think about the health of Fairbanks, we're thinking much more broadly than just the healthcare system.
And it's very complicated, because I can tell you the studies show I can be in the best healthcare system in the world. I can be sitting on whatever academic center, Harvard or Stanford or whatever you want to say, but if I have tobacco use, my life expectancy is going to be on average 8 years less, period. Regardless. Now, it may have been 78 because I'm in a good healthcare system instead of 70 in a bad healthcare system, but tobacco takes away 8 years, period. So there's certain things that have pretty significant effects there.
Another way to look at this is,
I'm sorry.
oh no, go ahead. The folks are here and we're wrapping around them. So the other kind of the community pieces wrap around those individuals. It's just another way of displaying that same concept, which is their individual makeup and their individual choices are not the only things that are going on into their healthcare.
This was a tough one for me to learn. I'll be honest that I grew up in a very different environment and background, and so I thought, well, just take care of yourself. Well, if you don't have health care, just move to where there is health care. Well, just make good decisions. And here I stand 40 pounds overweight, right? Talk about hypocrite, yeah. But what I found is sometimes the job is where the job is, or my family is where the family is, or I'm living where I want to live because of other factors. And so how do we help mitigate these things that can have an effect? Education is not available to everyone the same way. early life events, trauma and sexual and psychosexual events that occur can affect what happens when they're 40, 50, and 60. So we're starting to realize it's really complicated what goes into that outcome, and we need to be more focused on the entire patient rather than just where did I cut and what medicine did I give, right? There's a lot more that goes into that outcome.
So when we do our health needs assessment, at the end of the day, we're looking at health outcomes, but we recognize that we also need to be looking at those more immediate attributes or factors that are driving those health outcomes. So when we do our needs assessment, we're looking at all of those things up there. We try to be very data-driven, so we're trying to look at the data that's out there collected by other sources, and we're trying to gather some local data. And there's a swirl of stuff, and so our next slide shows the swirl, which is, we identified lots of needs in paramedics, right? There's some of them are like really big and jump out at you, and some of them are small. And so we are trying to think about, okay, for our next needs, our health improvement plan, we can't work on all 100 of those things. We don't have the bandwidth. And if everything's a priority, then nothing really is a priority. So we go through a process where we work with our community advisory board and work with our internal steering committee to go through and try to score these things by seriousness. How many people does it impact? Are there disparities? And then, how likely is it that we would make a difference if we worked on this in the next 3 years? So that's kind of how we come to our, at least Foundation Health Partners, our improvement plan.
And these make it so difficult because I can tell you tomorrow I can probably affect the health better than anything else by building a 150-bed outpatient long-term care center. That is not easy to do. There's a CON need, and it's not going to be financially viable. So all of a sudden that's easy to fix is not so easy to fix. And is it realistic? And are there things I could do next week that might have an impact? So it's tough when you start bringing all of that together and trying to make that decision.
So the last time we did this, these were the 4 areas that we selected. We were focusing on alcohol misuse, trying to educate folks about the adverse impacts of social isolation, building out our services for the older population, and working on gaps in the pediatric behavioral health continuum. Okay, that's one way.
Did I do that right? Sorry.
Yep, no, you're fine. So that's another way that we're trying to figure out what is our blueprint, where are we going to go next. So this is another way that we look at the data that's coming in. We do have patient experience data. We have people who, we survey them after every appointment, say, how was your experience? We also have, one of the other things that we're doing is we're trying to figure out, for our community our size, and how many physicians of different types should we have, and sometimes we do a physician needs survey. We haven't done this since 2017 was the last time we did it more formally, but I'm going to show some data for that. But we also do it a little informally where our primary care providers are saying, wow, I am having a real hard time finding a dermatologist for my patients. And
Or
so,
who am I having to send to Anchorage all the
to
time?
Anchorage. And so that's, we hear that from within our own system, so we get that feedback. So I wanted to show some slides from the 2017 study. We used a firm called Rampart. This is really the punchline here, which is they're saying, okay, in primary care within Interior Alaska, you have roughly 56 primary care physicians. We estimate for a population of your size, you should have 83, so you have a gap of 27. So they did that for each area.
You notice all of them were gaps.
They're all gaps, yeah. So I'm going to talk a little bit about how we use that and how we don't use it. So it's a guide, it's helpful, we're still using that study, but it's not the only thing that we're considering. So the next slide gives a little more data about how we got to those numbers. So he estimated the total service area population was 128,000. That's more than people who live in the North Starborough. So he was looking at Interior Alaska. He also brought in North Slope, the Nome area, the Kotzebue area. Those areas, to be honest, don't actually often access services from us. It's only if they're on a medevac flight that they would come to Fairbanks. Usually they head down to Anchorage because that's where the commercial airline flights go.
And we kind of have a divided system. Nome and Kotzebue both have access to A&MC and some systems there where they might rather go to Anchorage and get essentially free care and free lodging while they're there to see their endocrinologist or infectious disease doc rather than come here, so it makes it challenging.
And it's true also for the military population. They also have a separate health system, and they may be sending folks out for specialty care outside of out of Alaska. So when the consultant did this, you'll see that some areas, for instance, allergy compared to cardiology, estimated is really based on the incident of those needs in an average population. So he estimated that we would only need one allergist for 125,000 people. Well, we have a community that has a lot of birch trees and alder trees, and people are very allergic to those things. And so we actually have one allergist who is super busy. He's just run off his feet, and so we just hired a PA to help him. But that's one where those numbers didn't really hold up. We have more demand than we that this would tell us. And cardiology is another one where he was estimating you would need one cardiologist for every 30,000 people, and we have a population of about 100,000, so we need 3. Our cardiologists, again, are run off their feet.
At
So,
3.5 now,
Yeah.
they're still running off their feet.
but the example of like rheumatology is something that we don't have in town, and we do have a sense that we may not have enough volume for that, so that's something that we, service line that we haven't moved into because we don't know for sure that we would have enough business to keep a rheumatologist busy. So some of these areas, and we'll talk a little about some of our strategies, we might invest in visiting clinics and partnerships to bring people up and not have a full-time provider.
Telehealth and that sort of thing to supplement.
So next slide, just one more thing from his study. This is from his study where he was estimating how many hospital-based physicians would you need, not the clinic physicians. And this is not even 10 years ago, and there are some areas on here that we're looking at now he didn't even think of in 2017. So healthcare changes over time, and we'll talk some more about the hospital's lines that we are going to be adding. I started off by talking about patient experience scores.
Did we need, I think, yeah.
Yeah, I think I hit all of that. Cost of care is another thing that we think about when we're doing planning, right? So we are a nonprofit, but our mission is to keep our doors open. We want to have access to care in town, not just for this year, but for 10 years out for the next generation. So we're always thinking about, can we sustain the service? Are we going to be able to stay in business? So even for clinicians who think they're all about helping people, everybody in our organization knows that they have a responsibility to be good financial stewards. We've had, in not the too distant past, a couple of deficit years. We've come out of that, we're doing fine right now, but we always have a focus on financial sustainability. So we are looking at service lines. Would a rheumatologist be something that we would have to subsidize? If yes, can we afford that? Or are we thinking that we can't afford that right now? So we're thinking about those kinds of things. We're also looking at national benchmarks. What does it cost to deliver this service in other parts of the country, and can we get closer to that benchmark? So if you could run an imaging service for this amount of money in Washington State, why can't we offer that kind of service for that kind of money? So we're looking at benchmarks. And then I just threw up here, this is so arcane, but the Certificate of Need law is something that many states have, where they are saying to specialists, no, you cannot open up an imaging center, no, you cannot open up a new surgery center without demonstrating that there is enough demand for that there's a need for that in your community. I know folks think, well, that's very anti-competition, but we think from our perspective it's very important because we don't want to have basically all of the stuff that makes money operated by other people and the hospital left to deliver all the things that don't make money. We would not be able to keep our doors open.
100% of the time I can tell you what happens is if I own a surgery center and I also work at a hospital, anything that is private insurance that makes a lot of money, I do at the surgery center because I get my surgeon's fee, but I also own the surgery center, so when it makes a profit, I get a kickback. Not a kickback, but I get money, right? It's a legal kickback. Whereas then I only take my uninsured, or I take my Medicare that doesn't cover the cost of my Medicaid or TRICARE over to the hospital, or the emergency that's a higher risk, and then the hospital can't even pay its bills. So anytime you see private imaging or private surgery centers go up, understand that 100% of the time it is taking profit away from the hospital. I'm not saying that about anybody particular in town, but 100% of the time it is true in 100% of the locations.
So there's a tension there between us and our partners in the community system. Okay. So, does someone have a question? No, I was Dr. Hamm. Okay. So what are we doing in the near term? What are the things that are on our agenda that we're going to work on? So we have a 5-year plan that we adopted last year. This is our goal. We want to be a patient-centered integrated healthcare system that delivers excellent care. Integrated in a couple ways. We really wanted our component parts, the clinics, the hospital, the nursing facility, to work better together so that it's fairly seamless for patients. We really also want to be a little more a lot more patient-centered. It's not about what works for us as healthcare providers, but what does it look like to the patient? How are they experiencing the care? How can we empower them to make better decisions instead of telling them what we think they should do? And then really constantly looking at the quality piece of it. So these are, I'm going to start with the access to care stuff, the kind of the fun stuff, which is what are the new services that we are looking to offer or reshape. And so we had closed several of our specialty clinics. They are available from other providers in town. And then we realized that the other providers in town were swamped and our primary care physicians couldn't get people in. And so we have slowly but surely we're reopening some of these service lines. So big lift for us. It's a lot of work to recruit people to town and stand up a new clinic. But happy to say we've opened these 5 in the last 18 months. I want to talk a little bit more about team-based care. This addresses the provider shortage. We are not going to be, the times are changing, we know it's changing, we cannot be in the traditional system of it, just see a physician, the physician does everything for you, all that kind of come to your house and care for you throughout your lifespan. Our physicians are overwhelmed with demand from patients and the things that they need, and they cannot meet all of that demand, and there's not enough of them. We just can't recruit our way out of this problem. So we're trying to expand our team. We are thinking about what are the duties that the physician is working on that a nurse could do. The nurses are trained, and so if it's something that they are trained and qualified to do, to take that off the physician's plate and give it to a nurse. Similarly, we're thinking about, a few weeks ago, we had Jane in talking about the medication therapy clinic that we have and how we're using pharmacists as part of a team. So what are the other providers that we could bring into a team, make it a bigger team and not just a single physician. We are using what we're calling advanced practice practitioners, physician's assistants, nurse practitioners, to be on a team with a physician. So it might be, an example is Dr. Mangum. She has 2 PAs that are on her team. You might not see Dr. Mangum for your appointment, you might see the PA, but if the PA has questions, Dr. Mangum is there to kind of back up the PA. So we're doing a lot more in this area.
So 30 to 40% of all primary care is now delivered by an APP, an advanced practice professional. And when you think about it, most of the time, when you go into the provider, you want to refill on your blood pressure medicines, you need your A1C checked, I need my yearly labs. Do you really need an MD to do those things that I use the term when people go to cookbook medicine? Not that you're not important, but if you have hypertension or diabetes, there are certain things we do every year regardless of what you say. We're going to check your kidney function, we're going to check your blood levels, we're going to check your A1C. So there's lots of people that have the ability to say, oh, well, for your hypertension, let's go ahead and get this ordered, let's refill your meds, how you doing, blood pressure looks good. And it gets you in and out much quicker, it gets you in and out much more efficiently and at a lower cost, yet you still have a very high level of care, rather than the doctor can't see you for 6 months. So that team-based care, but then if something comes up, a question comes up, or, oh, your labs are abnormal, we need to do something, we've still got access to that provider, to that MD, that can step in if there's a more complicated issue. But team-based care is the future of healthcare if we're going to have access to care. It's not a matter of if, it is the only way to do it in the future. So for primary care, 95+% of clinics now have a team-based care model throughout the United States. It is the future.
One of the things I want to go back, we're working on is moving all of our clinics onto the hospital campus. There are a variety of reasons for this. Dr. Heckington talked about trying to get everybody on the same page in terms of our standards and expectations around quality. We are also wanting things to be a little more seamless for patients, so we are in the process of moving clinics onto campus and all the administrative services like billing off, which is very confusing for people who've come to the billing office and it's not there anymore. So just know that's something we're working on. One of the other reasons that we're doing this, however, is because we get paid more from providers if a clinic is hospital-based. And so that is one way that we're trying to get at the reimbursement rates are not covering our costs. All right, I'm gonna have Dr.
Sure.
Egerton talk about that one.
So 2 new hospital services, I'm really excited about this, it's been a long time in the making. So one of the challenges is we're gonna use the top one here, obstetrics. If I'm an OBGYN, I have a practice. In order to be able to have a practice 3 or 4 days a week, I need to be in my clinic, seeing patients, right? Seeing patients that are pregnant, seeing patients who may need gynecologic surgery. But if at 10 a.m. a baby decides to be born, where do I have to go? I gotta go catch the baby, right? Babies have a mind of their own. Well, the same thing's true at 2 a.m. So I may deliver a baby at 10 a.m., 5 p.m., 11 p.m., and 2 a.m., and then the next day I have to work. How well does that work, right? At some point, something's got to give. So from a provider standpoint and a patient safety standpoint, inpatient hospital obstetric service, meaning there is a MD that is an OB in the hospital 24/7. And that provider that's in the clinic can do what they need to do. And then if the baby comes early, right, we all sometimes hear about babies that are delivered in the elevator. I caught one in the elevator one time, and right as it opened, as we came onto the line, I reached over and caught the baby's head. Well, it's nice to have an MD there and not an MD who's across town in the clinic. It's not their fault, but they have a clinic they have to run. So from a patient safety and quality standpoint, this is going to elevate our obstetric service. From a quality of life standpoint for our providers, that they are all on board with this. We've started this. We have a medical director here. We've recruited 3 full-time providers that all they're going to do is the hospital shifts. That's also going to allow for the emergency department now to have access to them 24/7 in-house, so that anybody who comes in who's pregnant can be assessed by a provider, even if it's for a broken ankle or for heart problems. So same thing with acute care surgicalists. We are not a level 1 trauma center, but anything that goes to a big trauma center can also come here, just maybe not as often. We have car wrecks, we have gunshot wounds, probably more than other places. We might have moose attacks or bear attacks, right? We have all these things that may occur, but again, we have surgeons who are running a practice, they're trying to have a life, but these things can come in 24/7 without notice. So what we've done now is we've supplemented this by having surgeons that are in-house 24/7, or they're in-house all night, they're not doing a clinic, they're available 24/7, so that anything that pops up, they can be the surgeon, and not just for trauma, for colons that are somebody with colon cancer is having a problem, somebody who needs a chest tube, all of those sorts of things, so that we have people that are dedicated to doing that in the hospital. It's going to raise our patient safety, raise our quality, raise your patient satisfaction, and the surgeons are all on board, right? They love the fact that they can now dedicate their time in their clinic to their patients, dedicate their time in the operating room to who they're operating on, and maybe even get some sleep at night. So it's a good combination for everybody around. So those are 2 services that we've launched, and they're in the early stages, but they've been very successful, very well received, and they've really kind of raised the standard here.
We talked, we're working on adding a very small pediatric, actually it's adolescent, inpatient psychiatric unit to our hospital. We are currently sending all of those patients either to Anchorage or out of state. Very hard for families. They may have other kids at home, so do I go out of state with my kid who needs care, or do I stay in town? And so we're going to have a small unit, hoping that this stays or short, it can go back out to the community for more wraparound care. We are working on standing up a PET CT imaging line. This is something that we're fundraising for. It will help with cardiac studies and with oncology studies. It gives sort of a more accurate, in some cases more accurate diagnosis, and in some cases more better monitoring. How is the treatment progressing? Do we need to be more aggressive? Those kinds of things. So we're looking at that. Constantly looking at our equipment. Do we need to replace it? Some of these pieces are very expensive, so it's a dance between, it's not quite conked out yet too. We should probably fix it before.
Put some duct tape on it, let's keep it. So this is why when people say, well, we're not for profit and we made $1 million last year. This is why all of this is beyond what we consider not for profit. So we have to have money to be able to launch new services, replace equipment, expand services. And every one of these have a huge impact on patient outcomes. These are all patient-centered and all will improve patient care here in the Fairbanks area.
And as we replace equipment, then we get the new bells and whistles. So we have some really cool stuff going on at the imaging center. Okay, a couple other things I want to talk about. We are working with the other regional providers. We are trying to be more seamless. So they refer patients to us. We send patients back to them. We need to be able to work better together. We're trying to integrate our IT systems. We're trying to do a much better job of getting them discharge reports in a timely fashion. And right now, I'm working on a project where we're going to have a guide to services so they know how to make referrals so they don't get rejected. Project Unity is our big IT project. We have 14 electronic medical record systems throughout our system. It's crazy for providers. They have to look things up in multiple systems. It's a waste of their time. And it does mean that sometimes all the patient records aren't flowing through. So we're trying to get onto one platform. It's a big IT project. It will take several years, but it's something that we're working on that hopefully will mean that patients, when they say to their provider, I was in the hospital last week, do you have my records? They would say, yes, I have it right here, I knew that. So that's what we're hoping to get to. Okay, next slide, we're going to move along. Okay, we're working on lots of things to be more efficient. FHP Forward is something that we're doing to try to find waste in our system, and so we're teaching our providers and our staff those skills, how to look for waste and streamline. We are doing a lot around optimizing our OR. Dr. Heffington is leading that project with our Chief Nursing Officer. It's a very multidisciplinary operation. We just need our teams to work well together. Workforce development, this is getting at the staffing problems that we have. We're trying to do a better job of just growing our own employees here in Fairbanks and doing the training here. Next slide. We have to constantly maintain physical plants. Sometimes when we do that, we get energy savings and other good things come out of that. So Denali Center, we just put a new siding on it. It is actually warmer than it used to be. Midterm goal, this is not in the near term, but I wanted to put it up there. We are looking towards this. This may be 5 years out, 7 years out, where we want to build a new patient care tower at the hospital, move all the hospital units into one area because they're scattered out across a bigger facility, and some of our critical units are in the oldest part of the building. They're really cramped in there, so kind of eyeing this, which is why we're trying to be efficient.
The way we lay things out now compared to 51 years ago, I think some of them are 50 years old, completely different. The amount of monitors and the technology we have literally don't fit in the rooms because then they didn't exist, right? So it's just a difference in the way we do things now.
So we're a not-for-profit, but we are aiming to have an operating margin at the end of this year of 2%, and that is because there are things that we want to invest in. So when we talk about being in the black, it's very important to us that we have some money left over to invest. And then this is another activity where, when we first built the hospital 50 years ago, the community considered it their hospital. They had invested in it. It was very important to them. A lot has changed since then. We have new folks in town, and people don't realize that this is the community's hospital. We own it here. We run it here. We'd like to have more people engaged in thinking about what are the services that we offer. So I invite you to think of yourselves as part owners of a hospital.
And the real goal is if we provide it here, we provide good care, we really don't want people to make a choice to go to Anchorage or to Seattle just to be blunt about it. Because when they do, it hurts the overall mission. So that's why we wanted to stay here if we're able to provide it. Certain things we can't. We don't do open heart surgery or cardiothoracic surgery. We don't have the population of the system. So there's certain things that have to go out.
All right, that was our last slide. I'm sorry we ran through that very quickly at the end. But that's kind of how we think about what we're going to work on, and that's what we're working on right now. Any questions from anyone? And we'll have Carol run around the mic.
Carol? Of course I have a question.
I should have started over here.
You should have started with me. Well, having worked in the ER, what are your plans for when Congress gets rid of Medicaid and changes the workers' requirements, etc.? All those people that are now covered with Medicaid are going to pop right into the ER for their cold, flu, you name it. What, I haven't heard you say anything about ER today.
Sure. So that's a great question. So the question is about, particularly with the changes coming in, with Medicaid is a particular one. So we are actively working multiple different scenarios, not knowing where it's going to land. Right now we feel like what's probably going to happen is between 30 and 60,000 people in the state are going to drop off of Medicaid, and between 30 and 40,000 are going to drop off of the what's traditionally called Obamacare, the marketplace. Now, we don't know how many of those will get care elsewhere. In other words, are they employed and maybe they'll get care elsewhere, maybe their businesses will provide it, but most will not. For us, it doesn't change our care from the standpoint of we will still provide care, right? So that doesn't we don't even know when you walk in the ER or the urgent care, the providers don't know whether you're insured or not, right? So we still provide care, so it won't change the care. The issue is how much uncompensated care we may be providing. And so that's one of the reasons we're trying to become more efficient and lean, because we need to be able to make up for what is sure to be an economic hit to the system. We don't know how much. We're estimating about $2 million a year, which is not that much compared to what it could be, but $2 billion is a lot of money when you start thinking about it. So we have to be able to overcome that with efficiencies. We can staff differently. Right now, our emergency room is not busting at the seams, and our urgent care does have capacity as well. And a lot of those will probably end up in the urgent care if it's during the day, because that is a little lower cost, easier access. But we are planning for the fact that we may need to shift. We also work with our contractor, the emergency room doctors, and do they need to staff differently if we see a volume change? Because there's lots of things that could change, not just with Medicaid. There's talks about Bassett. There's talks about lots of different things that could have an impact. So yes, we are actively watching that. The problem is we can't go in any direction until we know which direction it's going. So, but we meet every 2 weeks. We meet about a cost containment. Every 2 weeks we meet about the possibility of what's happening with the healthcare system and have multiple plans in place. But who knows when we'll launch them? If you know what's going to happen, let us know. So.
Well, it's scary. It's
It
very
is.
scary.
Yeah. Good question.
Start over here if you don't mind.
And we have,
Just because you're close.
okay, right off the bat, I need to say for a town this size, as remote as we are, we have an amazing hospital. We're a town this size, and we're remote. For example, I go to Italy a lot, we go to South America a lot. Italy is less than 1/5 the size of Alaska, but there are 200 cities in Alaska, in Italy, with a greater population of Fairbanks. There are 50 cities with a greater population than the Woodstock Borough. And I think Adam and I are working for RFK Jr. and what's coming up. I don't know how you do what you do. Is there a way, can the community, individuals, establish a communication with the hospital, ideas, feedback? Was this it here?
Yes.
Okay, because I'll do that. Another thing, and we'll give this mic away. A few years ago in Italy, well, it was a woman from Italy who moved to France. She came up with a cell-free DNA test. Actually, she evolved it. And what that does is, and you know a lot more about this than I do, with a blood draw, it can predict 50 different types of cancer long before, and some of these things have no other test. Okay, if we could do more things like that. There's also in the American Academy of Ophthalmologists, they're talking about an eye test that can predict quite a number of things. Can we set this up so that you don't have as many late-stage cancers? I don't want my obit to say that, oh, he bravely fought bullshit, I'm going to go out screaming. You know, they follow this. What can we do ahead of time to anticipate these things?
Sure.
And can you further this, can you give another top question on what I do when I get sick? Because if I call TBC, as I have, like I got back literally with COVID, and the person at TBC said, no, you only get 10 minutes with your doctor in September or something. I said, well, I might. And the doctor said, well, that wasn't quite true, but I don't get to see the doctor for 10 minutes. What, give us what do we do if we get sick? And are there tests we can take to anticipate the inevitable?
Sure, so let's talk about the screening one, the predicting one. That's a great one. And it's a double-edged sword. So let's say I do a test and it says you got a 40% chance of colon cancer. What are you going to do differently? Well, you're going to get your colonoscopy, and you're going to eat healthy. You're going to try to lose weight, because all three of those are your impact, right? But what is our current recommendation for every patient? Get the colonoscopy, eat healthy, and lose weight. So there's value in that, but does it change what we do? What it does is it motivates the patient to make a difference. But from a provider standpoint, we should already be recommending those things. So every cancer that we can screen for, if it's financially viable, we already have a system in place. The issue is getting the patients motivated to do it, I think, is the challenge. Well, that is the challenge, right? So 88% of patients have some sort of non-compliance with the screening exam. Right?
Talking about different tests.
Oh, no, I understand, you're talking about the DNA one, but they're not 100% reliable. So what if I tell you got a 12% chance of pancreatic cancer, 19% chance of lung cancer, a 42% chance of brain cancer? What are you going to do differently?
That's the test that tells you right now that you have these in your system.
Mm-hmm.
And it doesn't say that, 10 minutes from now or 10 years from now it's going to happen.
Right.
But this is.
Right, these are the predictors, right. And that's what I'm saying, it's great information, but how does it adjust what we do in healthcare?
Like you're saying, it's
Yeah.
not a predictor, it's a.
It's very much a predictor. It will tell you, I can send you the information.
Oh, no, I know which test you're talking about, yeah, I know exactly what you're talking
But
about.
this is to say, you have tumor, it identifies exactly which cancer, what part of the body. That's more than supposition.
But it's not 100% accurate, and it doesn't get all cancers.
I haven't met a doctor
Yeah.
who's 100% accurate.
Correct, no, I agree, but again, what do we do with that information? So 99% of people, are they gonna have a cancer? So that's the question on screening. I could do a CT scan on everybody tomorrow and pick up cancers, but I would spend $30 million tomorrow. How many cancers would I pick up? Again, that gets back to, that's great healthcare. I picked up every cancer I can pick up on a CT scan. But for 96% of the people that take the test, it was a waste of money. Now, not really, it gives them peace of mind. So we look at not just the specificity, not just the sensitivity, what is the pickup, but the specificity. And those determine whether it's worth it. And then detecting it early through that method versus a different method, does that change the outcome? For example, for pancreatic cancer, it doesn't change the outcome. It's either stage 1 or it's death. Right? So catching it in stage 2 or 3 is great, except it doesn't change the outcome. Right? So does it change the outcome? Is it catching it enough? There's some things that it would. So it sounds great, and of course she's selling her test, right? She's selling her DNA test. But again, I can do lots of tests on everybody to pick up lots of things, but that is a huge expense. If you get a CT every year, it's going to pick up on some stuff. And it's going to cost, and it's going to expose you to radiation, right? If you get certain blood tests every year, it's going to pick up on some stuff. But for 99% of the people, right, it was a wasted test. So how do we balance that? So that's why we look at what is the risk of the disease, the cost of screening, and then the benefit of screening. So that's the challenge. As far as getting a hold of a provider, that is a challenge for us, and it gets back to we don't have enough providers. So calling in is a challenge to get access. We do have what's called the walk-in family practice walk-in clinic or urgent care, and it's open 7 days a week, 11 hours a day, and you don't have to have an appointment there. And it is associated with TBC, so they have access to those records, and then when they see you, those records go into your primary care provider. That's probably the best option I can think of as far as access. Good question.
Jane had a question.
Well, actually, your last couple of comments there are something that pertain to what I was thinking about here, and that is that when we're talking about the profitability and the percentages and this and that, and community support, community participation, community faith, all that sort of thing, I have been super active in the community for decades, and I find myself thoroughly disappointed at how many people really downplay and talk badly about the services that we have here. It's very, very hard to overcome that kind of publicity. The work that you're doing is incredible in order to actually put the value and the importance of all of this discussion that we're having here tonight. Additionally, I go all the way back in the decades to when Dr. Dunlap started the clinic across the river in St. Joseph Hospital, and Dr. Weston was in a little house on Noble Street, all that sort of stuff. So I have a real significant length of brush with all of the services here. I can also say that one time when one of the doctors here did send me down to Seattle for something, my healthcare there was probably the most disappointing and outrageous and poor quality of any that I've ever had in my entire existence. So it's just because you get this locked in that somehow or another we're substandard here, and then people kind of traded around across the backyard fence and so on and so forth. We need to have a super positive campaign with being able to have that faith in what's happening here. And I prefer the care that I have here. I seek to have the care here. I do not want it to be out of this area unless it's totally necessary. And I can think of only a couple of minor things numbers as far as minor goes, of where I've had to go elsewhere for something. However, those things are now being taken care of here. The work that you do is incredible. Thank you. But we need to demand more of our community to be supportive of the work that you do. And so I know you have a huge job there, and I know you are working on this, and it's not something I'm just bringing up as you're not thinking about, because I do know you're thinking about it. But it's very disappointing to feel that we don't give the proper credit and faith in the work that's being done.
We agree wholeheartedly with you, and a couple points I'll make to that. Number one is, when we look at our patient satisfaction surveys, if they are from outside of our area, we are rated extraordinarily high. Because people who live in the lower 48 come here and realize how good a care, the great interaction, the personal care. It's the locals that rate us the lowest.
That's right.
And the challenge is, if you're in Seattle, you don't know what the University of Washington or Swedish does, because 99% of the patients that go there don't know you and you don't know them. So you don't hear the bad, right? Here, it's hard to have a bad outcome when most of the population doesn't know about it. So that gets amplified, right? It gets amplified. And so we concentrate on, it's like, Seattle Children's wouldn't do that. Yeah, they would, you just wouldn't know it. There's a difference, right? And so our job as leadership is to make sure that our outcomes are where they need to be. That's our job. And then the community's job is to try to support the system with that. So as long as we're doing that, the community needs to realize that just because they heard of a bad outcome doesn't make it a bad hospital. Those outcomes happen at Vanderbilt and Stanford and Harvard. It's just you don't know anybody that goes to Vanderbilt, Stanford, and Harvard, so and you certainly don't know 30,000 people like you do here and hear the negative feedback. So yeah, it is a challenge. We have this, it's a bias is what it's called. We have this bias for this bigger system must be better, because one, they treat more people, and two, I don't hear the negative. But the issue is we only hear the negative here. How many times you go to a restaurant and don't tell somebody, McDonald's Big Mac was good, but you tell them the first time they get the order wrong, right? Same thing here.
I have a quick question.
So you said you use AI. Do you use it in your radiology department? Like, is it just a radiologist, or are you using an AI program that's also reading like a mammogram, or other, things you have done in radiology?
Right now, we are not utilizing AI to actually read it. We do have some decision support, meaning when there's certain diagnosis or criteria. There's good data out about radiology reading, but there's some challenges with that. We are using it in cardiology, so from an EKG standpoint, it can measure to 1/10 of a millimeter things that the eye can't even see. We're using it in the clinic setting that Corey talked about, and then with our new Project Unity, there's going to be some additional decision support tools. I personally think that is going to be a big effect, is when it says, did you realize your 56-year-old is on this and this medicine and you haven't checked it? It doesn't mean it doesn't do it for you, but it's reminding the provider, because the provider may know, oh yeah, it was done at their other doctor, so I don't need to do it. Or they may go, oh, I didn't realize they were on lisinopril, let me check the renal function once a year. So it's that decision support, that safety net. Radiology is certainly one of the areas that's going to do that. Cardiology, we're already utilizing that. Documentation. And then there's a whole side that the patient never sees, the scheduling of nurses, which is incredibly difficult, the flow of information, which is incredibly complicated. It's going to affect that actually more in healthcare than we realize.
So Dr. Wren is going to talk about, and when he gives his talk later this summer, he's going to talk about an AI product that he's testing.
And he's really, if you know Dr. Wren, he doesn't get excited. He's really excited about this. It is a fabulous tool. And the read is just instantaneous. It's amazing.
All right, we're keeping you really late. I'm very sorry that we ran over. I have too many slides. But
We'll hang around though for any questions or anything, but I know some of you probably have other issues, other plans.
Well, thank you, everyone, and I want to point out this booklet is on the back table. It lists all the coming lectures as well as other events throughout summer. And I hand you Jerry.